Now I take liberty of inviting Professor Ellen Robin, who has got two topics to cover. He is a very well-known figure in India. Probably he is more seen in India than his own country. And he is Professor of Ophthalmology, University of Michigan, and Associate Professor and of Ophthalmology and International Health, Johns Hopkins University. So he has got two: medical therapy, principle and adherence, and pseudo-exfoliation syndrome. Thank you.
Thank you very much, and it's an honor to be here.
And his timings are 10 minutes each.
Okay.
No, there, yeah, okay.
10 minutes, sir.
Oh,
Yes.
Thank you very much. It's an honor to be here, and I appreciate the opportunity. I'm going to talk to you about some work that we've done in both of my talks, both first about medical therapy and then about pseudoexfoliation. You know, when you see patients and you look at them, and this is a real patient and both eyes are about the same, who progress over a 7-year period, despite the fact that the IOP has always been controlled, you wonder why. Or if you look at the study, the early manifest glaucoma treatment study that showed the medicines do work better than no medicines, or treatment better than no treatment, but that half the patients still progressed who were treated, don't you wonder why? And I think the reason is we're blinded to the fact that we just don't talk to patients and miss the fact that patients don't take their medicines or can't get them in their eyes. And what I'm going to do today is talk about that. And I'm going to say that most of the blame is with us, not the patient. One of the reasons that patients look like they do well is because they want to please you. Patients don't want to come in and have you scold them. They want to make you happy with them. So this is an asthma study where they had an inhaler, and there's a microprocessor chip in the inhaler, and every time the inhaler was pumped, it registered. So the inhaler was dispensed. As you could see, patients did well for a while, then they forgot it for a while, so they took some extra inhalers. And then right before they came to see the doctor for a couple of weeks, they didn't take anything. But before they saw you, they took a lot of inhalers, so their asthma was doing well. Likewise with glaucoma. This is a slide on systemic hypertension from a great researcher called Virgins who work with Urquhart. And the green line is perfect adherence. The y-axis is your percent of patients who did well, and the x-axis is time. And this is a year study. There aren't that many one-year studies in adherence. And you can see there's an initial drop-off right here where people just don't even believe in it. You know, this isn't going to make me well. It won't do anything. Why should I even take it? It's too expensive or whatever. Then patients gradually taper off. The dotted line is different, and that has to do with execution. And that doesn't mean hanging something or whatever, but it means something we'll talk about in a second. So the first lesson, we have 5 lessons today, is ask patients if they're taking their medicines, because that means you care about them, and that'll really make a big difference. But there's a corollary, and that's don't believe what they say if they say they did take them. Adherence in ophthalmology is much different than it is in regular medicine. And why is that? Well, first of all, you have to get the drop in your eye. You know, unless you're dysphagic, you can get a pill in your mouth. And the other thing is various bottles are different. Now that we have so many generics in the United States, and you have tons of generics in India, all the bottles are different. And so there's different squeezability. You get more drops out. It's harder to get the drops out the bottle. There's been a couple studies showing that there's a real difference in different eye drop bottles as to how many drops you squeeze out and how hard it is to do. So if you have a patient who has a problem with their hands or paralysis or Parkinson's, ask them about that. There are 2 good ideas in eye drop bottles that came up. One was the C-cap from Betagan. This is levobutanol maybe 20 years ago. And sometimes if people take medicines, and I'm not on any, but did I remember to take it today or not, or should I take it? And there was either, if you took it once a day, there was a Saturday, Sunday, Monday, Tuesday on the cap, you just twisted the cap. Or if you took it twice a day, there was a 1 or 2, which is really sort of a neat idea. But because it didn't sell more Betagan, they never pursued it. Travatan had a dosing aid, and you can see this here, which actually helped you squeeze the bottle, and had a microprocessor chip in it that helped you remember to take the bottle and helped you and the doctor know what's going on. Didn't sell more Travatan, it didn't work. So lesson 2 is ask patients if they're having trouble with their bottles. If they're having trouble squeezing too much, too little, can't squeeze it. Important, it's physical, but it's very important. I'm going to talk about execution now. There's nobody with a noose around here. but it's the ability to instill a drop correctly. You can see here, this is a lady 4 days after trabeculectomy. I'm going to replay that for you again. I hope, right there. Well, maybe I won't. There it is. So I think she's wasting a little drop, so if you ever have a wound leak after a trabeculectomy, that may be why. And here's another lady. Hopefully it's going to work. There. There. Okay. These are all patients who say they've been on glaucoma medicines for over a year and have no problems taking their drops. So if you wonder why this patient has her pressure going up, it's because she doesn't even get the drop in her eye. She got it in her nose. This is a optometrist mother who's sort of wasting her drop and putting it in sort of weirdly. And this is the patient who says he has no problems getting his drop in his eye, and this is a modified version of punctal occlusion, in my opinion. So from some of the studies we've done, we found that patients don't do that well. If you look at people who can only get one drop in their eye and don't contaminate the bottle, you're talking about probably 20 to 30%. And different bottles from our study, although we didn't intend to look at that, did have different results. So lesson 3 is patients are clueless. They don't know if they're doing well. So remember to do that. Look at that. And the corollary is, if they can't get a drop in their eye, why are you giving them eye drops? So make sure that you look at patients when you prescribe eye drops. Take a bottle of artificial tears or something, ask them to put it in their eye. If they can't get in their eye, do SLT, do a surgical procedure, do something, but don't give them eye drops. Adherence or compliance, and this is really adherence, this was a misquote by Mike Cass. This is 40 years ago, and what Mike did was put a monitoring device, a microprocessor chip, inside of both a pilocarpine and a timolol bottle. And to measure adherence, what he did was, if you took the top off and turned it upside down, it would record that you used it. And we all thought, and you all use pilocarpine more than we do in the United States, that the afternoon dose or the evening dose was the hardest to remember. The answer is, that's not the case. It's really the nighttime dose is the hardest to remember. The morning dose is easiest. So for those of you who give patients prostaglandin and tell them they should use it at nighttime, you may want to reconsider. You may not be quite as effective, although it's not that much of a difference, but you may want to consider having them use in the morning. At least they get it in their eye. We also think of adherence as just a problem of too much or too little. It's also a problem of too much. Mike Cass has other studies with timolol, and 1/8 of the patients were took their timolol more than 3 times a day for at least a week in a 1-month study, which is pretty impressive. There was an article that just came out, I saw about this, a gentleman talking about too much, who had 217 COVID shots in the last 4 years. And why he did, I don't know, but that's really an example of a little too much. We also did a study with microprocessor chips looking at the difference between 1 and 2 drops. That is, if you use 1 medication or have 2 and 1 adjunct medication. And in the 1 drop group, most people did really well. And in the first drug for this, for the people on 2 drugs, people did pretty well. But as soon as you add the 3rd line, as soon as you add a 2nd drop, people do horribly. So the bottom line is, as we said before, simplify the medical regimens. Don't just add medicines. Try a different class of medicines, use a combination medicine, but just don't keep on adding medicines. I'm going to finish this with the doctor-patient relationship. We all think we do great. We love our patients. We talk to our patients. No, we don't. This is a study we did that was published a few years ago where we had 15 different glaucoma specialists, well-known people, seeing 279 patients. All either were newly diagnosed or had their medical therapy changed. And as you can see, we had a camera in the room. We video recorded the whole interaction. Doctors and patients both signed informed consents, and the doctors thought it was all about the patients, but they all performed best. So this is the best case scenario. You can see that at both at the initial visit, the 1-month and 3-month visit, the doctors did not talk at all about how many drops they were supposed to take, how long they're going to use it, why they were taking it, and even which eye to put it in. This is pretty horrible data. I mean, we do a horrible job. We had a focus group recently looking at what patients really want to know. And these are common things, but we don't tell them these things. We're really bad at this. You know, what's glaucoma? What is an ideal IOP? Why do I have to take these dumb visual fields like Dr. Asrani was talking about this morning? And why am I taking these medicines? What are their side effects? We don't mention any of these things. We don't even have our assistants do it. So my suggestion is, you can see the slide, take a picture of it, and give the patient a note card. Have a little thing in your waiting room, and say, you know, have them ask 3 questions. And that way you're ensuring that they do something, you're interacting with the patient, and you accomplish a lot and show that you care. Thank you.